Because I'm Dr. Sokol, I'm one of the pulmonologists.
Hello.
Glad we could get the appointment moved up with the weather coming.
Yes.
Sorry to keep you guys waiting a little bit, but I wanted to make sure that we had all the information back to the talks. I'll let Brooke finish. I don't distract.
Do we have good news or bad news?
It's just news. There is no good news. There is no bad news. It's just news.
Oh, that's not good.
It's not good news or bad news. We're gonna talk.
I did not do any questions, just vital, sorry.
That's okay. That is okay.
Dr.
This is
Carr,
time.
one of the pulmonary fellows.
Okay, so what were you told? I was wondering where families were starting from before I dig into it.
The blood test got escalated to a second blood or a retest, and now here we are. So we don't have much information.
Okay.
Yeah, that was the last one. Then we just did the swab test.
Okay. So the test you're referring to is this with a newborn screen.
Right.
We look for a lot of different conditions. Some are genetic, some are not. That the purpose of the newborn screen is that everything that we look for in the newborn screen are things that have much better outcomes when care is initiated early.
Yep.
And so, Jack, the biggest thing was the cystic fibrosis. What do you guys know about cystic fibrosis? How much did we go on Google yesterday?
A little bit. Just, I mean, we talked to our pediatrician, stick to Mayo Clinic, or not Mayo, whatever, Cincinnati, another couple other websites.
Mm-hmm.
Not down any, like, YouTube rabbit holes, but...
Yeah, we both were not familiar with it.
Uh-huh.
She explained that it's a disease of the lungs and GI at times, or always maybe. And no cure, but lots of treatments. That was kind of it.
Okay. So a very cursory over. That's good. I'm glad you guys didn't go down any rabbit holes. Okay.
Yeah.
So I'm going to cut right to the chase. The newborn screen that you got done, they do look for, the first thing they look for is something called an IRT, or an immunoreactive trypsinogen. And that's a substance that is released by the pancreas, which is one of our digestive organs, which is impacted in cystic fibrosis and in other conditions. But when the pancreas is stressed, that substance is in higher quantity. Okay? And in this case, it was. Not astronomically so, but high enough to send
Us
off
here.
for, well, then the newborn screen then sends for genetics. Okay. Historically, they would just repeat that IRT again, but it ended up missing a lot of children who would have otherwise benefited from early interventions with treatment. So now what the state of Tennessee does, and actually the majority of the states in the U.S. do this now, is if the IRT is elevated, they then send for reflex genetics. They send off a genetic screen that looks for some of the most common mutations for cystic fibrosis. Okay. Today there are over close to 3,000 known mutations. Obviously they don't screen for that many, but they do screen for the common, depending on which state you're anywhere from 35 to 50 most common mutations. And if you have one mutation, if you have two mutations, or if you have an astronomically high IRT, you get notified by the newborn screening department through your pediatrician, and you get sent to us. That's not the end of the story though, because it's useful information, but it's not the whole story. And so for Jack, so his newborn screen came back, his IRT was elevated, and they did send off genetics, and they did find two different mutations in those common mutations for cystic fibrosis. Cystic fibrosis is what we call an autosomal recessive disease. It means you have to get a mutated gene both from mom and from dad in order to have the condition. And so with the two mutations that Jack has, I'm fairly confident that he does have cystic fibrosis. Okay? I was fortunate that I'm one of the CF docs, and so it was nice that I was on call so that we could meet and talk, because again, that's not the end of the story. Okay? So let's talk a little bit about cystic fibrosis. We're going to start very kind of cursory and kind of go into it, and then hopefully by the end of this, I see the tears starting, but I'm hoping by the end of my talk that's not how you're going to be feeling, okay? Because if you had to choose a time and date to have a baby with cystic fibrosis, now is it. And especially when we talk about the genetics that Jack has, there is a pretty big silver lining to the mutations that he has. Okay. So again, CF is a genetic disease. You require 2 mutations, so a mutation from mom and a mutation from dad to have this condition. But that's not the end of the story, because the mutations alone don't necessarily tell you what the disease is going to look like, because we're not just one gene. So we have kids who have the classic mutations, like Jack does, that were picked up early on newborn screening, who do absolutely fantastic. And kids who have these rare mutations that shouldn't cause much trouble at all, who do not so fantastic. Part of that testing that we do is something called the sweat test, which is a more functional test of that channel that is not functional in CF. So in cystic fibrosis, there is a channel that moves salt across cell membranes. It's something called Cystic Fibrosis Transmembrane Regulator, or CFTR. You don't need to remember that, but that way, when you do some reading, because you inevitably will, and you see this, you're like, that's what Dr. Sokolow was talking about. I remember hearing about this. But there's no test on this later. Cool. Okay? But that ability to move salt across membranes has a lot of implications in living. We need to move salt in order to move water. Okay? And so a lot of the organs that we're going to talk about with cystic fibrosis, the gut and the GI tract, the lungs, all are dependent upon this channel to function normally. But so do the sweat glands. So the sweat is a really nice way to look at the function of that channel. So the mutations that Jack has, he's got his one mutation is delta F508, which is the most common mutation in cystic fibrosis. 90% of patients with CF have at least one copy of that, and about 70% of patients actually have 2 copies of that. That's how common that mutation is. The other mutation, again, you're not going to need to remember this, but he has a 3849 10KB to C mutation.
Yeah.
Not going to remember that. And that one is typically kind of classified in the more mild spectrum of mutations, but it is one of the more common mutations that we find. And that's going to have some implications as we kind of move forward in our discussion. Okay. I know, I'm boring you already, Jack. Although I am rather envious of this head of hair that we have came out blessed with.
Okay, dude.
And a very expressive face.
Yeah. He's been very alert since minute 1.
With most combinations of mutations in cystic fibrosis, that channel doesn't function very well. And what we typically see is elevated amounts of salt in the sweat. So the sweat chloride gets a little bit tricky. Anything below 30 milliequivalents of salt is normal. Anything above 60 is abnormal. But as you can see, there's an intermediate range between 30 and 60 where the function's not normal, but it doesn't give us a diagnosis definitively. Care to guess where Jack decided he was going to land?
Somewhere in between?
And we're in between. So we do sweats on both sides just to maximize our chance. Oh no, we'll get that clean. Maximize our chance of getting a result. Because sometimes babies this age don't like to sweat. He sweat well, but the values were 31 and 47. So both of them in the indeterminate range. So we will have to repeat that moving forward. Though based on his mutations, we do, we are 98% sure, 99% sure he's got cystic fibrosis. Okay? So the sweat test is one thing. It tells us, again, a functional thing. We will retest him again. Oftentimes at this age, just kids don't sweat as well as we'd like. And so around 2 months of age, we'll repeat that sweat chloride. And I am willing to bet that we will find a value over 60 at that time. Okay? So the biggest reason that we screen babies so early has nothing to do with the lungs. Even though you're seeing a lung doctor and CF is now taken care of primarily by pulmonologists. That wasn't always the case. Historically, cystic fibrosis was a GI disease. I mean, people have known about cystic fibrosis in some form or fashion for a long time. You can go back to medieval textbooks,
Yeah.
and they have things like, Lord save the child who tastes of salt, for he shall surely die. They knew back then that something with kids with cystic fibrosis was abnormal, and they didn't live very long. And the reason that kids didn't live very long historically is the majority of patients with cystic fibrosis have something called pancreatic exocrine insufficiency. They don't produce enzymes to digest fat. We worry a lot about fat in America for the other reason, but in the newborn period, in infancy, the majority of the calories that we need to grow and to thrive come from fat. Breast milk, formula, all high in fat. Pound for pound, it's very dense in energy. And so you can imagine if babies don't have the ability to break down fat, I know, bud. They don't thrive. They fail to thrive. They have a lot of nutritional deficiencies. And so the reason that we do the newborn screen has really little to do with the lungs directly and more to do with nutrition. Okay. Interestingly, that second mutation that we were talking about, not infrequently, children who are born with this mutation combination do still have functioning pancreases. Not always, but sometimes. And so when we start talking a little bit more about Jack specifically, we're going to ask a little bit about how he's been pooping, how he's been eating, and how he's been growing to try and get some indication as far as if the pancreas is still functioning. And if he is kind enough to bless us with a poop before you all leave.
Yeah, so far there's been like a speck. We'll probably need more than a speck.
We'll do what we can. We'll send that off looking for something called fecal elastase to give us an idea if his pancreas is functioning and how well it's functioning. If it's not functioning, what we typically do for our babies with cystic fibrosis is replace what the pancreas doesn't do for itself. And if the pancreas can't produce digestive enzymes, we give kids digestive enzymes. And if you look back at the history of cystic fibrosis, one of the biggest things that we did in medicine to help kids thrive with CF was the advent of digestive enzymes. They no longer had failure to thrive. They would grow appropriately. Okay? They'd be able to thrive. Okay? And so, way back in the 50s when that started, we saw a huge improvement in survival in cystic fibrosis. Okay? Along with problems digesting fat, there are certain vitamins that we take in, vitamins A, D, E, and K, which require fat absorption to get into our bodies. And so historically, kids with cystic fibrosis also had some deficiencies in those vitamins. And so we supplement those for our kids with CF at pretty high levels to make sure they get those vitamins. Okay? Kids can be prone to things like constipation and greasy stools. Constipation is from the gut also uses that salt channel to keep the intestines nice and lubricated and moving, and sometimes that can get backed up and can get constipated. Sometimes kids will develop kind of greasy, oily looking poops. That's pretty much just the fat going through and not being digested. Okay. Obviously the lungs must be involved, otherwise you wouldn't be seeing a pulmonologist for this. So just like the gut and the pancreas require that salt channel to make secretions fluid, the lungs do as well. And so historically, kids over time develop lung disease from infection, inflammation, and mucus plugging. And we're going to talk more about that on future visits, less so today, more just about the fact that there are things that we're going to do as far as helping mobilize secretions, making secretions thinner to really improve outcome. The whole reason that we screen babies and get involved early is the nutrition. Because we know kids who do well nutritionally early in life grow better, have better lung function. So nutrition is going to be the really big key part for Jack moving forward. CF is not the reason, stay off the internet. The one place I will have you look is the CF Foundation. There's a lot of information, even on some other hospital systems you can probably find good information, but the CF Foundation is where all that information comes from all those places. We are in kind of a golden era for CF care. and while there's not necessarily cures, we do have some new medications, some of which have been out now for close to 10 years, to improve that function of that channel. The oldest of those medications, one that kind of came out, I think is 2012, if I'm remembering correctly now, is a medicine called ivacaftor or Kalydeco. And that drug was really game-changing for cystic fibrosis. Unfortunately, it only worked for about 5% of patients with cystic fibrosis because the mutations that it would work on were rare. Fortunately, Jack has one of those mutations. So that second mutation that I told you was going to be kind of key in this is one of those mutations that this medicine works on. Now for those kids with delta F508, the other mutation that we have, there are now medications that are also available for those patients as well. But they are much newer and their age of approval isn't this young. So the medicine that we'll eventually start Jack on is now approved for about 4 to 5 months of age. We can start this medication depending on weight. And my guess is, with how he looks right now, we're not gonna have any problems getting there. So, completely game changing. Right? So a lot of those kind of complications that you will inevitably read about online, Jack has a much lower chance of developing because of, the fortunate part is that he has one of these mutations that allows us to start a medication incredibly early to completely alter the course of the disease. If you look in a textbook or look at old information on cystic fibrosis, it's still considered a life-limiting disease. But I tell families now when I give this talk is that in this era of these new modulator drugs, I expect kids to have a completely normal life expectancy. Okay, so all those kind of hopes and aspirations that you had for Jack, none of that changes. You're going to still expect him to do well in school. He's not allowed to break curfew. He's not allowed to be mouthy and not do his homework. I mean, none of that, all that stuff that you were going to do anyway stays the same. Okay? You have a completely normal child who just happens to have cystic fibrosis. And again, now in this day and age, all those kind of things that you expected for him are going to hold true. Okay? With some caveats. The kids who really do well, the kids who kind of stick with the prescribed therapies, they take their enzymes. And again, it's easy now because, do you have other kids at home? How many kids do you have at home?
We have a 3-year-old with brain cancer at home.
I heard about the 3-year-old. We're going to talk about that in a little bit too. But
this does too.
The malignancy aside, 3-year-olds are tough, period.
Yeah, he's been the hardest part of having 2 is his acting out. And but
which is age appropriate for a 3-year-old.
Yeah, he's fine.
Wait till they're teenagers.
Yeah.
Because a lot of stuff too, because even with the 3-year-old and all the medical stuff that you're going through with him, kids are amazingly resilient. And yes, they will act out and have their issues, but they really much want to please.
Yeah.
And they're so much more resilient than any of our adult patients ever are. Because the whole reason that we do pediatrics, and also Dr. Carson said this a million times. The reason I do pediatrics is you make a kid better, they go back to playing. You make an adult better, they find something else to bitch about.
Yeah, totally.
Right? And so, while this is, I'm sure, for any family, this is incredibly overwhelming with the diagnosis. I'm sure for you guys, it's even more so. I think in some ways, this may be easier than the stuff that you're going through with your child. In some ways, it's going to be a lot harder. And then the cumulative things are going to really add up. I'm using that as my intro to the fact that you're not doing this by yourself. Okay? The whole reason that we want to get kids in early to see us is to support families. From the educational standpoint, all the stuff that we talked about, again, there's no test in this. You're not going to be required to remember any of this. It's going to take some time to kind of get up and running. A lot of the things that we're going to do, we don't start everything at the same time. We're going to focus mostly on nutrition right now, and then slowly add things on as families are comfortable. There's no prescribed time. We have to start this on this date. Now, obviously, the fact that Jack qualifies for a modulator, that new drug that I was talking about, I am going to want to get him set up for that as soon as we can, just because I think that's going to make the rest of your lives a lot easier. But you're not doing this by yourself. So from the CF side of things, there are 4 providers that take care of CF. So there's myself. I'm the associate CF center director. Dr. Brown is our center director. She does both the director for both the peds and the adult side. We have Cynthia Driscoll, who's one of our nurse practitioners, and then Caroline Thomas is one of our other providers who does CF part-time. So there's 4 of us that you'll see intermediately. Okay. I'm glad I got to meet you today because I don't get to see a ton of the babies because I'm not usually here on Wednesdays unless I'm on service. But I do see patients on Fridays as well. So if there's days that work well with your appointments that you're doing for brother
James.
Yeah.
Jack and James.
Jack and I like that. You know, we can do our best to kind of accommodate that as long as one of our providers is here who does CF.
We're flexible.
It's not just providers though. I mean, we have I have three clinical fellows. Dr. Carr is one of them, and so if you guys need anything at any hour of the day, even overnight, and you call, someone's there to answer the phone. We have respiratory therapists. The person you're going to meet sooner rather than later is Sarah, our nutritionist, to kind of help with the enzymes and the growth and the weight gaining. We have a social worker because again, just like I'm sure you've met with the oncologist, they have social work teams as well. I mean, this is a lot for families to go through. Navigating insurance, navigating school, daycare, all FMLA, all those different things that inevitably kind of like rear their heads. We don't, it's fine. They're, none of us are probably old enough to remember home ec in great detail. But like, the whole idea of home ec back in the day was to get people ready to be able to run a home. They need to reintroduce that, but they need to do stuff like, how the heck do you apply for insurance? How the heck do you, start a lawnmower? There's so many things that, the younger generation has absolutely no idea how to do anymore.
You sound like her father in taxes.
I was going to mention taxes too, but, these things you guys are not expected to be able to do by yourselves. And so we do have a social worker. At some point I'll have you meet Stephanie Rushing. She's our CF Center coordinator. So when there's questions come up, hey, we need more supply, you have someone to talk with about these things. Okay. There's inevitably people I'm forgetting. We have a pharmacist that helps with the medications, and then the list goes on and on. So you're not doing this in the vacuum. So much like I'm sure you guys hopefully have experienced with the oncology group.
Yeah, they've been great.
You have a big team supporting you to take off any weight that we possibly can in helping you guys thrive with this. Okay. And I usually share with families too. I mean, the reason that I do this, I have 2 friends with cystic fibrosis, and they were born in the 70s when we didn't have a lot of things that we have now. And they're still doing wonderfully because of the advances that have happened over the last 40-something years. And again, you'll see stuff online about the average age, life expectancy, stuff like that being in the 50s and 60s, depending on what country you're in. Don't think that holds true for your son. Again, the people who are presently dying from cystic fibrosis at 50 or 60 now went through the majority of their life without the therapies that are going to be available to Jack in the first couple months of life. Okay? All that said, what questions do you have? I know it's a loaded question.
Good TED Talk.
I've done this once or twice.
Yeah. So we are both recessive carriers. Every child we might have in the future will not be having in the future. In theory is 25% positivity rate. So that was true what we saw. Cool. Just curious. What? The medicine that he has a mutation for makes up for some of his deficiencies. How 25%, 100%, 50%?
That's a great question.
And what are the deficiencies? Or what would they
what the medicine does, so this doesn't change a ton of care. So the reason, one of the best prognostic indicators for patients with CF is actually how close they went to a CF center. So you've already done well with that.
Yep.
But not all CF centers are created equal. Again, we're toot my own horn a little
Yeah.
bit. Our CF Center is actually fantastic. We have some of the best outcomes in the country. And what separates us from the number 1 center, I think we're number 4. I mean, we're talking fractions of a percentage. I mean, the top 10 centers in the country really aren't that different. We have colleagues at all those places. We're doing the exact same things. And the reason that our outcomes are so good is that we're really aggressive. You know, we're going to make sure that, you know, we're not missing anything, that we're getting all the things that he's going to qualify for. We don't take no from insurance very easily. We fight pretty hard, tooth and nail, to make sure that our patients get everything and anything that they possibly need.
Luckily, we have great insurance.
But you'd be amazed.
Yeah,
even
I
with great insurance, there's still a lot of hurdles to
Good to hear.
to kind of get through. The question about the function returns is a great question because it's kind of a loaded question.
Correct. Sorry.
So with different mutations, we have different degrees of dysfunction. I didn't want to get too deep into the science on our day 1 because I didn't want to. I know we're already overwhelmed. Life is incredible.
I'm also 2 weeks postpartum and very hormonal, so.
For sure, and you know this is happening during a pandemic where the world is absolutely nuts. I mean, you know, what else could we possibly add? I get it. This is not easy for anybody, and I think, you know, with the other circumstances that you guys have, I mean, I'm amazed you guys are handling it as well as you are. The function is an interesting question. So, as carriers, you only have 50% function, and that's plenty. And as you start decreasing the amount of function, you get more and more problems. So individuals who have 2 copies of Delta F508, the first mutation that Jack has, have almost 0 function. Okay? And they have all the classic findings of cystic fibrosis, the lung disease, the pancreas problems, etc. As you start to increase, we probably only need to be around 30% function to have relatively normal lungs. Get up around 35, 40, and the pancreas starts working. So it's hard to know what percentage he has, because again, even kids with the exact same mutations, we have other channels that try to make up some of the difference, and you may have a really great, robust channel, or you might not. And so we can't necessarily quantify how good that function is. Like the sweat test, which is our one quantifiable test, how high or how low it is does not correlate at all to severity of disease. You can have a sweat test of 120 or 61. It makes no difference. It's positive, and it doesn't give us a good indication as far as outcome. However, the second mutation, the 3849 mutation that he has, is what we call a gating mutation. So Delta F, the first mutation, that protein doesn't form correctly, and our cells go, I don't like that protein, it doesn't look right, and it breaks it down. It doesn't even get to the cell membrane. The gating mutation one, it looks pretty good, and it gets to the cell surface, but it doesn't open. The ivacaftor, the kalydeco drug, is in essence a key. It forces that channel open. With that being set with the case, we're going to probably push function up to like 40 or 50%. So close to carrier status. Some of the new drugs that are out there for the Delta F508, we have kids who have 2 copies of those mutations. They probably have more function than their parents. The caveat to that is that damage that's been done can't necessarily be undone. So you can improve the trajectory, but things don't get undamaged. And what I mean by that is kids who are born with pancreases that don't function don't typically get their function back. For boys, most boys with Delta F508 homozygote mutations, the more severe mutations, they have congenital absence of the vas deferens, meaning they have a hard time getting sperm out and they want to have kids themselves. Some of the mild mutations, when I used to practice in Cleveland 10 years ago, I took care of adults too, we had some who had some residual function. Some of them found out in unfortunate ways when they were teenagers. So he's going to still get my sex, drugs, and rock and roll talk eventually, if that's specific to CF, because it's important. It also doesn't protect them from STIs.
Yeah.
But it's hard to know how much function comes back, but what we do know is, so with the ivacaftor, that kalydeco drug that Jack qualifies for, when we studied it initially in adults, these are patients who lived, again, decades without having something like this in their lives, they saw improvements in their lung function of 12 to 14%. So huge improvements in function, even in their state. It doesn't unfortunately take away a lot of the other aggressive things that we're going to need to do to keep them healthy. If the pancreas isn't working, we're still going to have to take enzymes. We still supplement vitamins. We still do things like airway clearance to keep the lungs healthy, but it's not a perfect replacement.
So is that the next sort of thing to understand, is pancreas productivity or functionality?
Right, and so I'm going to ask a little bit about how much he weighed at birth, how he is now, to get an idea of how well he's doing from a growth standpoint. We look pretty healthy right now.
Mom's been a champion of feeding and feeding and feeding.
He was 6 pounds 13 ounces at birth, which was on the 22nd of December, and then at the first pediatrician appointment, which was on the 28th. Trying to remember.
Not a
Have to look at the calendar. He was 6 pounds 7 ounces, and then we took him back on Monday, and he was 7 pounds 3 ounces, and then today he was 7'9". So I think he's doing good, and he's poops and pees pretty much at every feeding.
Okay. Does it ever appear greasy?
No, it looks pretty breastfed poop to me so far.
So I think, typically, so kids, if he was delta F, I would be starting enzymes today.
Okay.
Being the fact that his combination is very frequently pancreatic sufficient, at least to start, we're going to hold off on starting enzymes until we get the poop back.
Okay.
How much is he eating at a time? Like how long, I should say?
I recorded all of it. I have an app.
Long?
It depends, but I would say average, anywhere from 10 minutes on each side to 25 minutes on each side.
Okay.
So it just kind of depends.
Okay.
I was, especially to get his weight back up, I was doing every 2 hours during the day. And then at night, when he wants to be nice, he'll sleep for like 3-hour stretches, but sometimes it's like every 45 minutes, depending on the cluster feeding. So he eats well. I mean, he definitely.
And you're feeling good letdown afterwards?
Yeah.
Good. Okay.
And I've been pumping a little bit, which I started doing after the first appointment to see if he was actually taking enough. So we're doing like a bottle a day right now, just to whatever is left over after the first feeding. So yeah, it all seems to be good right now. Is there anything I should be eating? It doesn't matter right now.
6 pounds, 13 ounces. Write it down before I forget.
Sorry, I kind of just started firing off.
Nope, you're good. After he's had a feed, does he seem pretty happy? He doesn't seem like he's ready to eat again. I mean, there will be the cluster feeds.
Yeah, it depends, but yeah, for the most part, especially the past week, like week 2, I feel like he's usually, during the day, I try to keep him awake after he eats.
I mean, he just fed.
Yeah, he just ate before you guys came in here. Yeah, he's honestly, like, compared to our first, he has been like
The opposite. Chill, quiet.
super chill, barely cries, like weird. Like when he came out and we were in the hospital, I was like, this is weird. Sorry, because James was like,
weird, just different.
it was great.
Yeah.
We'll take it. We'll take it. But James was just like,
Probably also growing a tumor.
right, like he was super fussy. So it's been a nice change. So yeah, he seems like a pretty content. The most mad I've ever seen him was that sweat test.
Well, I mean, he doesn't like being restrained.
Yeah.
It does feel a little like pins and needles, and so some kids are just like, what the heck is
Well, when
going
we
on?
unwrapped him, his whole head was wet, so I was like, he's just hot. And as soon as we got him unwrapped, he was good.
And he's spitting up at all.
Yes, not a ton. I'd say in his whole 2 weeks of life, like 3 times. But nothing crazy. There was like one sort of full mouth vomit, but otherwise just kind of like little dribbles.
Okay. Do we know of any past family history of anyone with cystic fibrosis?
The only
Grandpa's brother, grandpa's brother, great
my paternal grandfather's brother died of cystic fibrosis 40 years ago. I did not know that until yesterday when I asked my family. He had a lung and heart transplant, apparently.
Yeah, I think we don't do those very much anymore.
Yeah.
Seems so aggressive.
And then we have no idea on your side.
Yeah.
And Jack was full term.
Yes.
Any complications with the pregnancy?
Just gestational hypertension.
Controlled with medicine.
Mm-hmm.
Other questions that you guys have for me?
So, I guess symptom-wise, like, what are we looking for?
So right now, primarily we're looking at nutrition stuff.
Okay.
Okay. So if it's always tough in this case because again, you've done this before, especially with breastfeeding. Like your supply is going to be based on his demand.
Right.
And so as he grows, his demand's going to go up. He's going to do those cluster feeds. Your production's going to go up, and he's going to level out. If you start having periods where he's cluster feeding a ton, it's been going on now for weeks, and we have not had. You know, I feel like my production's up.
Yeah.
He still seems unhappy. That's what I want to be looking for.
Okay.
If the stools start to change, I mean, this is the force part of you having had a child before, you at least know what you're looking for.
Right.
If that starts to change, we need to know about it. So a lot of it will be nutrition. His weight. Now, you're also going to see us very frequently up front.
Right.
More so if we have to do things like enzymes, because the enzymes are going to be based on his weight. And so if the enzymes are doing what they should be doing, he's going to grow tremendously, and those are going to need to be adjusted frequently. So typically in the first couple of months of life, we see kids every week to 2 weeks.
Okay.
A lot of that's for education, a lot of that's for family support. And a lot of that's based on the fact that, you know, right now, Jack's going to grow faster than he is during puberty. I mean, I think about how big your 3-year-old is now compared to where he started.
He's a giant.
Those, you know, if we grew that fast during puberty, I mean, the NBA would be, you know, oversaturated.
Yeah.
And so, a lot of it's going to be based on nutrition. Obviously, you know, there are some respiratory concerns, and kids at even younger ages can have some respiratory concerns. And so one of the other reasons that we see kids very frequently is we're going to do some throat swabs, looking for certain types of infections that can cause problems in CF. The most notable is an organism called Pseudomonas, which we typically associate with things like hot tubs and saunas. It likes to be in moist, wet environments, warm environments.
Don't have either at home.
CF kids aren't allowed to be in them. So we do look for those, so that if we find it, we want to treat it early and try and get rid of it before it likes to set up shop in the lungs. Okay.
Is there anything physically we would see in his mouth or throat or anything?
How immunocompromised are we? Like,
From him?
Yeah, him. Not yet.
The immune system works.
Okay.
It's just that because the lung environment is different, it doesn't have the ability to clear organisms as well. And these organisms that, again, like the reason that this bacteria likes saunas is that it likes warm, wet environments, and that's what the lung ends up providing. And it goes, this isn't where I usually live, but this seems like a good place to be, and that's where it is. It may hold down the road some other implications if James has to go through any more therapies that affects his immune system, we may have to have some conversations with your oncologist as well as far as what's going on with Jack, just to make sure that we're not putting James at any risk. I wouldn't expect that to be the case, and I think especially since, around 4 months of age, we will get Jack on the Kalydeco Caftor. Kids who are on those drugs typically don't grow these bad organisms. So we don't see a lot of those organisms in this age period, and that we can get them on the drug early. I'm hoping we don't see those.
Okay. And in terms of stool to look for, is it mostly just greasy, but really like any change?
Mm-hmm.
I'm trying to picture what greasy would look like.
So, we've all been out in the parking lot after a car's had a little bit of an oil leak, and you get that kind of like that oily sheen.
Yes.
It's hard to say because again, those mustard seed poops always kind of look shiny.
Yep.
It's almost like like a oil vinaigrette where the oil separates. You'll see a little bit. It might be subtle, but you'll see that.
Should I just take photos?
Absolutely. I see plenty of pictures of it.
Cool. Sounds good. Okay, so that's really the only thing right now that we need to be.
Yeah. And again, this is, we're going to be your support network for this. If something changes and you're like, I'm not sure if this is normal baby stuff or this is CF stuff, you always call us first.
Okay.
And you're seeing Kate Seymour as your pediatrician.
Mm-hmm.
Kate's great.
Mm-hmm. She's awesome.
Yeah. I was trying to figure out, so one of my partners, Carolyn Thomas, who actually knew about y'all before I did, I'm sure Kate called her.
Yeah.
Because I think they're friends.
Kate's great.
Mm-hmm.
She's far away from us, and we drive for her.
Mm-hmm. So, I remember her as a resident. She's great.
Yeah, she's awesome. So you said we'll likely be seeing you guys like once a week right now.
Mm-hmm.
What, if any, other therapies are in the future? Or like, what does that look like?
Probably nothing. It'll probably just be us and your pediatrician for, well child checks, vaccinations, that kind of stuff. But, yeah. Again, he's completely normal.
Yeah.
He just happens to have cystic fibrosis. The one thing the thing will be a little bit different is, we do, at least when you're here, you'll see us wear these. This is not to protect us from anything that Jack has. This is that, I see other patients with cystic fibrosis and other nasty things. I don't want to bring anything to him.
Okay.
So.
Okay. I'm sure
I think I tell families, and especially mothers, not to exclude you, Dad, but
No offense.
likeliness is that you're not the one breastfeeding at 3 a.m.
Correct.
You've done this before. Those questions, those doubts, those worries like to percolate when we're sleep deprived.
Right.
You have 2 children under the age of 4. You're going to know what sleep deprivation is.
Yeah.
And so I usually recommend to families is keep a pad and paper. Is you probably have a place that you like, the rocking chair, the glider, where you're doing most of the feeds for Jack. Keep it there, because these questions are going to pop up at 2 o'clock in the morning, and then by the next morning, you're going to have like, oh, I had that great question, now I can't remember it. And this way too, it's not going to help. It's not going to be. You're not going to perseverate on it overnight.
Right.
You need to get rest too.
Yeah.
You have 2 boys who need your attention, and I'd say even
3.
I wasn't going to go there.
What child?
My wife would probably agree to those kind of things as well. But I found that most families, and this is you too. I mean, again, you might be up, with James, and I hate to ask that question. Write them down. It takes the weight off you, and you won't forget them. You know it's written down, and it's ready to go.
If this is kind of what I've done. Well, not that question, but if he gets sick with something else, say COVID or pneumonia or something that is of the lungs, what do we? Is that? Do we obviously be more concerned, or is it right now maybe not?
That's a loaded question. We'll come back to the COVID in a minute.
Okay.
Kids with CF get the normal things that kids get.
Yeah.
So even before you had the tumor diagnosis with James, I'm sure he got the sniffles and the colds and stuff. And with Jack having, I'm sure, a very once we get over the jealousy stuff, loving and attentive brother, pissing on him, he's gonna get those viruses as well. That's okay.
Okay.
Jack's immune system works. Okay? And it's not those kind of colds and stuff that we get worried about. So usually when that happens, you let us know, hey, James came home from preschool or whatever, and he got a cold. He has a cold. Now Jack's got a little bit of runny nose too. That's fine. What we usually do is we watch, and so because typically viral illnesses peak around day 5 to 7, and they start showing improvement. Double checking.
I already did earlier.
And if we see that normal kind of childhood illness trajectory, perfect. It was a virus. Don't worry about it. If you know what, Jack had a viral illness, and now we're at day 10, 11, it's not getting better. Then we see him.
Okay.
We swab him, make sure that he's not growing something abnormal, make sure that the weight's still going well, because oftentimes when kids with CF are fighting off some more significant illnesses, they spend more calories repairing than they do grow, and we often see the kind of a growth either stop or decrease a little bit, and that may raise some concerns.
Okay.
Back to the COVID question. So now, first of all, we'll put that tail on again. You have a 2-week-old.
Mm-hmm.
So we shouldn't be out in the world anyway.
Right.
We don't because of James.
Right.
Anyway.
And so hopefully that will mitigate some of that, but it won't be 100%. COVID. So any child is at slightly more risk with some of these more recent strains, including things like Omicron, than we were with the original strains.
Right.
That is regardless of cystic fibrosis, that is regardless of malignancy, chemotherapy, immunosuppression. We are seeing kids in the hospital who have no medical problems get admitted with COVID. Thankfully, while it is affecting more kids, it's still a respiratory virus. It's usually from respiratory things or if they're flaring from other conditions that they have. The vast majority of patients, kids who are getting COVID, are still doing absolutely fine.
Yeah.
And so there's not a great answer to that, and especially too. And I'm sure this is going to be a much more charged topic for y'all, given James's situation. The way that, especially with Omicron right now, it's incredibly infectious.
I know.
You can do everything right and still get it.
Right.
I mean, you look at the number of right now, the healthcare providers are getting decimated, and believe me, we're the ones being overly cautious. It's just, it's there. I mean, we're seeing a lot more of it too because we're putting ourselves in those situations, but even doing everything right, you can get hit with it. Are you all vaccinated?
Yes.
Triple.
Perfect. I am incredibly hopeful. So I'm
We're science believers.
no, again, just I make no assumptions.
Yeah.
And I try to be as non-judgmental as possible for those who are not.
I'm sure it's hard.
Because there's oftentimes in families who are not, there are some extremes, but the vast majority of people who are still, I think, hesitant, it's because they've gotten a lot of bad information.
Yeah.
And my role is to provide more rational, correct information in hopes that they can balance out and they will come back. But my hope is on the side note. Other hat that I wear is I do vaccine research with our vaccine group here. So I'm really hoping that I have a 4-year-old at home too, who's not yet vaccinated because it's not available. We're hoping that by February or latest March, we'll see FDA emergency authorization for a Pfizer vaccine. At least down to 2. So hopefully that would help at least James. And then hopefully, soon thereafter we'll get down even younger. And at some point, we'll see that cross between where the age that we're at and go approval.
Okay.
With him starting the drug at 5 months, 4 months, is there a more important window where he can't get? I guess what I'm trying to say is
No.
do we take a deep breath at 4 or 5 months? Okay.
No, you take a deep breath today.
Cool. James,
This is not a fast process.
Yeah.
And so again, the fact that we have it available at 4 months, I think, is probably appropriate because there's a lot of other stuff we have to kind of get used to before we start putting on this drug. Because there are some risks to the drug. I mean, it can cause some inflammation of the liver, which we monitor for very frequently. Kids who are born with congenital cataracts, sometimes those can get worse. One of the things that we will have you do for Jack is get his eyes checked. I wouldn't do it right now though, because Omicron also is a very quick virus. We saw in our South African colleagues,
Yeah.
it peaked about 4 to 6 weeks and then dropped. We can wait for his eye exam.
Yeah.
We ain't going there.
We have James starting school in January.
Uh-huh.
We are on the fence about that in the first place.
Mm-hmm.
You can't answer this, hypothetically.
I can answer hypothetically.
I mean, are we putting ourselves and him at greater risk by having him go to school?
If you have the option,
We have the option to do whatever the heck we want.
Here's my opinion as a physician and as a parent. If you have the option to wait maybe until February, I think you'd be better served. Because I really think Omicron's going to burn through pretty quick. I think you'll have, especially because you have a newborn baby at home.
Right.
You have 2 boys who are going to have very different but still challenging risks to mitigate. I think he'd be fine, honestly.
Right.
If you say no, we have to go back to where I don't have a choice, I'd be like, it's gonna be okay. But at the same time, if it's like if you can wait 2 or 3 weeks,
We can.
I would.
Cool. Then we also have him, James, at an outdoor sort of camp.
Mm-hmm. Masking?
No.
The instructors.
Instructors do, but it's 15 kids outside, probably sharing boogers, and so maybe
Kids-
hold
kids
off
are
on
gross.
that. Yeah.
It's tough. I mean, right now it's such a charged time because
Yeah.
people are coming back from holidays. We live in Tennessee.
Yep.
Vaccination rates aren't great. Where do y'all live?
East side.
East side. So again, a more affluent community where people have money to travel and likely did.
Yeah.
And so I think the next 2 weeks especially are going to be a little harried. After that, I think I wouldn't blink about it.
Yeah.
Cool.
Okay, I guess.
I have nothing left.
You will, and that's okay.
No, I meant just questions.
No, I mean, but you will. That's okay. You don't have to, this is again the I tell all families as a diagnosis is that the first year is always the toughest because it's all these unknowns, and you don't feel like it now. But I guarantee, I'm going to ask this again when he turns 1. How do you feel now compared to where you started? You're like, oh my gosh, so much better. It's like this is nothing. Like we were so overwhelmed because it's unknown. I'm sure with James's diagnosis and now Jack's diagnosis, the unknown is what makes things scary.
Yeah.
The first year's a lot of unknowns, right? He's going to develop who he is. Will he stay calm and even keeled? Hopefully.
Mm-hmm.
There's no guarantees.
Mm-hmm.
There's always one that breaks the mold. I'll introduce you to my 4-year-old someday.
We were like, James was
Crazy.
a fussy, screamy, crying baby.
Yeah.
And then he got brain cancer, so we're like, maybe this one will be a little more, stress-free. So far, he is. And that just led me to
I feel like it's not going to be that much of a lifestyle change for us, sadly. And also positively, we're already kind of doing most of the things we're probably going to have to doing for him.
Mm-hmm.
So,
I guess in my cancer mom brain, is there anything we need to look for that's like an immediate ER visit?
He always calls first.
Okay.
CF, thankfully, does not move as fast. I mean, if he stops pooping, if he,
Right.
the normal, like, those kind of things, you call us first, but there's really not much anymore. We used to give a talk on CF emergencies to our trainees. We just don't see them anymore.
Okay.
CF's not what it used to be.
Okay.
For much the better.
Cool.
Here's those eyes.
Keeps peeping.
Mm-hmm. There's a lot of open eye sleep.
creepy. Should we see if he pooped? Do you think he pooped?
Well, I'm going to examine him, and
Okay.
oftentimes that's the
That'll
impetus
get
to let the flies. All right, my friend, let's have a look at you. I know you're all nice nice and warm with mom, I'm gonna take you away just over here.
No.
And I'll probably get some baby snuggles in too, because
Please
my
do.
boys don't let me do that anymore.
Oh, I just read.
Although my 4-year-old did climb into bed with us, that's why I was late this morning. My 4-year-old did climb into bed with us this morning, and then out of nowhere decided he was going to pee the bed. He hasn't done that. That's not that in 2 years.
Wow, lucky you.
Like, oh, kid. Hi.
That's a big stretch.
And I'm not expecting to find anything abnormal on our exam today. I know. I am going to irritate you a little bit and see if I can get you to poop for us. Oh, I know. Oh, big stretch. So from the nutritional standpoint, you're going to hear us talk a lot about not just weight, but also where we are, our weight for length. It is kind of a way of looking at almost like body mass index. So when kids get bigger, we start looking at body mass index. We're not calling you fat. We're not. We try to target around the 50th to 60th percentile weight for length. It's an indication that he's got enough calories in to be growing. Because when we don't get enough calories in, you were much happier with mom, that's where we're going to go back. I know mom's going to keep me. It's cold. If we don't get enough calories in, the first thing that we start dropping is our weight, followed by our length, and then our head growth or brain growth. And so we can use that metric to give us an idea of how well we're doing nutritionally. For bigger kids, we start using BMI. We know that BMIs over the 50th percentile historically have been tied to much better pulmonary outcomes. With the modulators and all the other therapies that we're doing, we used to say just over 50% was great. We've had to kind of rein some kids in as they start hitting the 99th percentile. Well, let's bring it back. Okay, so.
James
No.
was off the charts fat for a while.
Which is how I wanted him.
Big little one should be.
Now he's off the charts height. He's super skinny and like 10 feet tall. But some rolls good.
So, what I would suggest today is, since we would have gotten past birth weight, we expect him to have some pancreatic deficiency. We'll get a poop from him. And I'm going to plan on having you guys come back and see us on Wednesday next week.
Okay.
If that works for y'all. Either with Dr. Brown or Cynthia Driscoll. I want you guys to meet all of the team. For our CF patients, we take care of close to 300 kids with cystic fibrosis. And we don't have individual panels, so I don't see a certain number of them, and so we all see them together. That way, if I'm not here, or Dr. Brown's not here, and you guys call, it's like, oh yeah, what's going on with Jack? And so it's that team approach.
Okay.
Feel a little bit better?
Yeah.
Not great. I know this is not. I would have much rather said nope. It was a false alarm, but
It's just weird, man.
yeah.
It's like we got dealt poopy cards, but it's okay.
Or maybe you're just getting all that life stuff out of the way early. So we're all gonna
At least
deal with
we're-
challenges in our lives.
I'm just happy we're in Nashville next to a good children's hospital.
Yeah.
And all of these experiences and things, it always amazes me. So like, when I was in training, one of my co-fellows, did a journal club one time on this really rare tumor that was. Why are you talking about this, bud? It was a case report of 12 kids who had this really weird tumor at it was a small case series, and he was one of those cases. And now he's a pulmonologist, and so his life experiences changed his, led to his focus in life, and we're all given those kind of things in different degrees, and it just makes us who we are. And this is going to make James who he is, and Jack who he is, and change how you guys we're going to be as parents, and all sorts of ways that you can't even expect, and we'll be all right.
So should I try and feed him and see if he'll poop?
Absolutely.
And then my other question is, do you guys happen to have wipes here? Because we use
Absolutely.
wipes.
Dad packed a diaper bag.
Fine.
We changed diaper bags.
This is not an